the diabetes. We're going to talk about the complications of diabetes. Okay? Yesterday, we did a summary of the metabolic changes that occur within the human body due to deficiency of whether it's real deficiency as in type 1 diabetes or relative deficiency of insulin due to ineffective function due to the rise of anti-insulin hormones, okay, or resistance due to this. Okay, so yesterday we wrapped up the metabolic changes, the various metabolic changes that occur within the body, okay? And today you have a title in your books that is called Mechanisms to Explain How Hyperglycemia Causes Vascular Complications, okay? This title is not very, it needs a little alteration, okay? And I will tell you why, okay? And I talked to the head of the department, and it's going to be changed hopefully next year, okay? But these are the complications, generally speaking, of diabetes. Why? The first question is, why do diabetic patients get cataract? Why do diabetic patients get cataract? This is related to, cataract is, does anybody know? Opacity of what?
The lens eyelids.
Of the eyelids, excellent. Opacity of the eyelids. Normally glucose is present or enters the eyelids, okay, such as any other part of the body. Most of the glucose is shunted into oxidation via the... No, something more common. Glycolysis, okay? Mostly glucose enters glycolysis within the cell to extract energy from glucose, yes? In addition, the excess glucose, okay, which is normally not much, because we are under, this is a normal person, okay? Normal person, not a diseased person. The rest of the glucose enters a pathway known as called the polyol pathway. Polyol pathway. What is this polyol pathway? Glucose is converted into its alcohol or reduced to its corresponding alcohol, which is sorbitol. Sorbitol, okay? And the hydrogen donor in this case is NADPH. NADPH. Normally, in a normal person also, the sorbitol is converted into fructose, okay? By the enzyme alcohol dehydrogenase, or in our specific case, sorbitol dehydrogenase, okay? Which utilizes oxidized NAD, converting it into reduced NAD. This is not present in your books, but I'm giving you the background because these are just a line, so I'm giving you the background behind this talk, okay? This is for you to understand why what's written in your books is already there. So sorbitol is converted to fructose. What happens to this fructose? It is phosphorylated to fructose 6-phosphate, okay? And then it joins glycolysis, okay? It then joins glycolysis. So this is in a normal person. So there isn't a surplus of sorbitol within the cell. Please note that. How about in a diabetic person? In a diabetic person, the blood glucose level is elevated, much more elevated. The patient is hyperglycemic, okay? So much more glucose enters tissues, okay? Especially those tissues that do not depend on insulin for entrance of glucose, okay? One of them is what? It's the eyelids. So surplus of glucose enters these tissues. Normally, the affinity of the enzyme that is responsible for synthesis of sorbitol from glucose is not high to glucose. However, when you get a lot of substrate, in case of a diabetic person, okay, this pathway is increased. It increases the production of sorbitol. And for some vague reason, the second part of this reaction does not occur very well, which is conversion of sorbitol to fructose. So the body or the lens, eye lens, ends up with a lot of sorbitol that accumulates within the cells of the eye lens. Sorbitol is, it cannot pass to the outside of the cell because the cell membrane is impermeable to sorbitol. So what happens? A lot of sorbitol is present, and this sorbitol attracts water. Okay? Therefore, the net result would be damaging of the eye lens and the development of cataract. Okay? So this is all related to the polyol pathway that I just talked to you about. A lot of sorbitol and no fructose. Sorbitol accumulates because cell membrane is impermeable to sorbitol, attracts water, damage, and cataract. Okay? And blindness consecutively in patients, in diabetic patients. Okay? So this is the theory behind cataract development in diabetic patients. Okay. Not only are complications related to this, but also, do you remember that I told you that conversion of glucose to sorbitol requires reduced NAD or NAD pH, okay? It consumes, because this is a pathological condition, as we said, it consumes a lot of what? A lot of NAD pH. So a NAD pH, enters in a lot of other needed reactions, such as the reduction of the regeneration of reduced glutathione. What does glutathione normally participate in? It participates in a very important function, has a very important role, which is maintenance of the membrane integrity, cell membrane integrity, okay? Protection of the cell membrane integrity against oxidative stress, okay? So if I do not have the reduced NADP to regenerate glutathione, therefore the effect of ROS or reactive oxygen species that are present in our cells is aggravated, okay? And it leads to oxidative damage of the cell membrane, okay? This is another thing. And also, NADPH, this is not written in your books, but this is for your own interest to know the whole story. NADPH also participates in the formation of nitric oxide. Nitric oxide, have you heard of nitric oxide before? It is generated from the amino acid arginine, okay? By an enzyme known as nitric oxide synthase. You're going to take this in the individual amino acid metabolism, okay? But the importance of nitric oxide is that it is a vasodilator, okay? So this vasodilator is not produced as well as in normal persons. So this is a vascular complication actually, okay? The thing is, this title that has to do with vascular complications, the cataract part, the damage of the eye lens, does not fall under this title, okay? That's why I told you the title is not very accurate, okay? So, these are two complications. Another complication would be something called glycation of proteins. Glycation of proteins. Please note that glycation is different from glycosylation. Okay? Glycation is a slow, non-enzymatic process. It's written. This part is written. It is a slow, non-enzymatic process that occurs in the body. Okay? Where glycation of lysine residues of a protein, okay, it's followed by oxidation and therefore alteration of this protein and its damage, leading to the formation of a group of products known as H. What does H stand for? Advanced glycation end products. Okay? H. Advanced glycation end products. What's the problem with H? There's a different structure of the protein, if you see. Okay? Therefore, it does not function properly. Okay? What happens? Let's take, for example, fibrin. which is known as factor 1A. Factor 1A of what? Coagulation factors. Okay? Coagulation factors. Fibrin is factor 1A. It comes from fibrinogen. This is not also written. This is for your own interest. It comes from fibrinogen by the action of thrombin. So thrombin converts fibrinogen into fibrin. And this fibrin, what does it do? It acts as a mesh. You know what a mesh is? Yes? Like a net. Acts like a net. For the formation, which platelets are entrapped, for the formation of what? Of the blood clot. Okay? So when this fibrin is glycated, okay, fibrin is resistant to degradation. Therefore, there is more liability to development of what? Blood clots, okay, and their persistence, and hence the vascular damages that result from diabetes. Okay. Another thing. Not only fibrin is subject to glycation, also another protein, which is apolipoprotein B, which is the star protein of which lipoprotein? Low density lipoprotein, LDL. Okay? LDL, apolipoprotein B is present in LDL. And this is used for, it's a transport vehicle for which cholesterol. Okay? So when apolipoprotein B is glycated, this alters its shape so that the receptor of the LDL does not properly recognize the LDL. Okay? So this results in decreased clearance of LDL from the blood. Okay? Therefore it persists more, and therefore it may be deposited in arterial walls leading to atherosclerosis. Okay? So these may be called vascular complications. The glycation of proteins, as I said. Oh, and by the way, these age products, okay, these advanced glycation end products have certain receptors known as RAGE receptors for advanced glycation end products. When they bind to their receptors, they lead to inflammation. They trigger inflammation. Okay? So not only is the function altered, but they have receptors to which they can bind called RAGE, bind to RAGE, okay? Triggering a global state of inflammation all around the body. Okay?
Doctor, do you understand the meaning of age? Advanced glycation products.
Advanced glycation end products, يعني glucose when it rises in the blood, okay? Hyperglycemia, persistent hyperglycemia, okay? Slowly this glucose binds to these proteins, especially the lysine, the amino acid lysine and the proteins.
Any protein?
Spontaneous, yes. Lysine, especially lysine, especially the amino acid lysine. And lysine enters in a lot of proteins. That's why you can find it in a variety of proteins. Okay? So, these are the vascular complications of diabetes. The next thing that we're going to talk about, something very important to you as future clinicians, which are the types of diabetic coma. Types of diabetic coma. Okay? This patient is already hyperglycemic. Please note, a diabetic patient is a hyperglycemic patient with low glucose tolerance, either due to absolute absence of insulin from his system due to damage of the beta cells, or insulin is there but it cannot act properly. Okay? We're going to talk mainly about type 1 and type 2. So you have this table in your books, and I always like to, when I study, I always like to study from tables, okay? Such that any other points you want to add, you should add to the table, because it's much easier, at least for me. Okay, so what types of coma are diabetic patients liable to? One of two types, either hyperglycemic coma or hypoglycemic coma. okay? Either hyper or hypoglycemic coma. And in hyperglycemic comas, there are two types of comas. The first is diabetic ketoacidosis. Diabetic ketoacidosis, okay? And from its name, the main problem will be the rise of
ketone bodies in blood.
ketone bodies in blood, okay? The increased production of ketone bodies. As I said about the complications, I'm going to talk just a little more than in your books, but this is for you to understand the background behind this. Okay, but the age part, the rage part, and the things, other things that are not written in your book, are not going to be asked in the oral exam or in the. But this is for your own interest so that you. So let's talk about diabetic ketoacidosis. First of all, we have to know who is more prone to this type of coma, okay? And who is more prone, type 1 or type 2, and we have to say why. So these are the first 2 points to know or to remember. Diabetic ketoacidosis is more common in type 1 diabetes mellitus. Type 1 diabetes mellitus, okay? What is its cause? What is its cause? The patient, as I said, is already hyperglycemic and he is not getting his proper dose of insulin. Okay? He is not getting his proper dose of insulin. Not only that, the condition may also occur or may be aggravated by the increase of what?
Carbohydrate
Of
feeding.
anti-insulin hormones. Yes, the counter-regulatory hormones. Such as what? Such as any stress that this patient is subjected to, like maybe infections, okay? Infections, or psychological stress, or anything that can increase the counter-regulatory hormones of insulin, okay? Or the anti-insulin hormones. The cause of coma, as they state here, is ketoacidosis. Ketoacidosis. But where does this ketoacidosis come from? Where does this ketoacidosis come from? We said in diabetes there is a decreased consumption of glucose due to lack of insulin. Yes? So the body resorts to the other source of energy, which is yes, beta oxidation of fatty acids. Okay? And the opportunity is very well very well there because lipolysis is promoted, yes, because hormone sensitive lipase or hormone sensitive lipase is more active, yes, because of the anti-insulin hormones are taking the upper hand. Okay, so lipolysis, beta oxidation, production of acetyl-CoA, production of acetyl-CoA. This acetyl-CoA inhibits the enzyme pyruvate dehydrogenase complex. Okay? It inhibits further production of acetyl-CoA. This is the negative feedback, normal negative feedback mechanism. Yes? And it also promotes the action of the enzyme pyruvate carboxylase. Okay? Leading to production of oxaloacetate. The question is here, why is not this oxaloacetate shifted into the citric acid cycle to produce energy as it normally?
There's enough energy leading from beta
yes,
oxidation?
Enough energy, yes. How is this reflected in a feedback mechanism?
ATP ratio when it elevated inhibits
yes,
the key enzymes of Krebs cycle?
And also, yes, very good. And also, we have the NAD, okay, in the reduced form. This is produced also from beta oxidation. Okay, so this inhibits what? Inhibits the citric acid cycle. Okay, so I have a good amount of oxaloacetate, which is shifted to production of glucose via gluconeogenesis. Okay, so the surplus of acetyl-CoA and reduced NAD, okay, are the key parts of diabetic ketoacidosis. Okay, always remember, this is not written. I think you should take notes of this part or write these two compounds. and you can correlate them. Okay? So, I have a lot or further production of glucose, but the body cannot consume this glucose. So the acetyl-CoA is also shifted to production of ketone bodies, which is acetoacetate, beta-hydroxybutyrate, and acetone. Okay? Their production is increased in the liver, and then they are supposed to be taken by the blood to various organs so that they can consume them as a substitute for energy. So the production is increased, and remember, this is a diabetic a patient that is not taking his proper treatment, proper dose of insulin, and also under stress. Okay? So he is under extraordinary conditions. So a lot of ketone bodies are being produced, and the level is elevated in the blood. Okay? Normally the blood, as you know, has a buffer system that can deal with excess of acids, these acids. So at the beginning, if you take pH, you'll find that the pH is normal, but then you have a hint that the bases are decreased. Okay? This is a compensated case. Later on, if the condition is left untreated, you'll find that the pH is decreased. Okay? Because the patient is ketotic. Okay? It's under acidosis. So what do these acids, what's the net result or the picture of this patient? Okay? This patient has acetone odor in their breath, okay, in an attempt to eliminate or remove acetone from the body, okay, these ketone bodies. The patient is also not only in the breath, the patient has a certain breathing pattern called cosmal breathing, which is shallow, okay, rapid breathing. Shallow, rapid breathing, okay? Also in order to eliminate these ketone bodies. So it says here that respiration is hyperventilation, which is, I think you should write cosmal breathing. It's not written. It would be useful. Shallow, rapid breathing. Okay. How about these ketone bodies? How does the body try to get rid of them? It flushes them in what? Ketonemia is always followed by ketonuria. Okay? Ketonemia is followed by ketonuria. But, and also take care that this is an uncontrolled diabetic patient with probably a glucose level above the renal threshold. Yes? So they also have hyperglycemia and glucosuria. Yes? Excellent. And glucosuria. Therefore, osmotic diuresis follows. So this patient is dehydrated. And the diuresis maybe it's very severe, yeah? And these patients may die from dehydration because maybe up to 6 liters. 6 liters may be lost in the urine, okay? Around 100 milliliters per kg of water is lost in this condition. Okay? So, severe dehydration. How about the electrolytes? Electrolytes are also lost. They also pass in urine. And please take care here that in an attempt to solve or to make better this acidosis, there's an exchange between hydrogen ions, okay? Hydrogen ions in the extracellular space, and potassium. So potassium is shifted outside the cells in exchange for hydrogen ions. Okay? So potassium is also lost in your hypokalemia. Especially hypokalemia is evident. So that's why he said that the skin is dry. This patient is dehydrated.
Hypokalemia or hyper?
Hypokalemia. The net result of potassium in the body, okay, is decreased. Hypokalemia. Okay. And the pulse is rapid and weak. Why weak? Because the patient has hypovolemia. Okay? Rapid and weak. And rapid, why is it rapid?
To compensate the rapid shallow breathing?
No. To compensate something else. Perfusion. Okay? Volume is decreased. So in order to get to the tissues, I need to what? Increase the work I'm doing. Okay? Plasma glucose level is of course high. Of course, urine glucose and ketone bodies are present. This patient, keep it at the end because we're running out of time.
I'm just asking for closing the door.
Okay. This patient is also, you can see him nauseating and vomiting, okay? And this is especially the effect of the ketone body beta hydroxybutyrate, okay? Beta hydroxybutyrate leads to nausea and vomiting. So this was the first type of coma, which is diabetic ketoacidosis, and this is a very important medical emergency, okay? Because death may follow, okay? Death of the patient may follow. Okay. So this was regarding the diabetic ketoacidosis. You don't have a lot written about it in your books, but it's very important to know. You should know it as doctors. And the correction of this condition would be, what would you expect?
Insulin dosage.
Insulin, excellent. But there's a bigger emergency than insulin. Something that must be tended to immediately. This patient will die of dehydration. Dehydration, okay? So you should rehydrate the patient and give him the proper electrolytes with that, okay? And also treat the acidosis and insulin, of course. Okay? The second type of hyperglycemic coma would be the hyperosmolar, hyperglycemic, non-ketotic coma. Hyperosmolar, hyperglycemic, non-ketotic. Please note the difference between both. Non-ketotic. This is very important. So, which is more common? Which type of patients? This is more common in
Hyperosmolar?
hyperosmolar. In type 2 diabetes mellitus patients. Type 2, and usually this patient is there's this certain criteria, let's say clinical picture. Mostly they are elderly patients, okay? Hyperosmolar, hyperglycemic, and blood glucose levels are very high, maybe above 700 milligrams per deciliter, okay? Very high blood glucose levels, and since they are old, they are not really getting the proper treatment. That's the explanation of hyperglycemia. And they are also, they usually have another disease, a disease which precipitates the condition, infection or whatever, okay? Pneumonia, UTI, there's an infection. Also stress, some sort of stress, and they are also not drinking, okay? They are not drinking. So it is more common in type 2 diabetes disease. By the way, ketoacidosis can occur in type 2 diabetes mellitus, okay? But if there's some sort of aggravation for their anti-insulin hormones, maybe they're taking, they may be taking cortisol for treatment, drugs, okay? So ketoacidosis can occur in type 2, but it's more associated and more common with type 1 diabetes mellitus, okay? What's the deal with these hyperosmolar, hyperglycemic, non-ketotic coma patients? But as I said, the anti-insulin hormones are elevated for any condition, stress, infection, or even psychological stress can trigger that. Okay. So, the cause. First of all, these patients are hyperglycemic, as I said, very high blood glucose levels. However, they are non-ketotic. They are not prone to ketosis. You may ask yourself why. Well, the cause is not really known. So there are theories related to the subject, such as the so these patients have hyperosmolarity. These patients are dehydrated and they don't drink enough, okay? And they are losing water in what? They are losing water in urine because of the hyperglycemia that is already there, osmotic diuresis, okay? Very high blood glucose levels lead to osmotic diuresis, okay? And also,